हाँ, मैं देखा। हाँ हाँ, बस 2 मिनट, डॉक्टर जीते भी ज्वाइन हो जाए तो चालू कर देते हैं आज। Yes, good evening, Pankaj bhai and Hiren. Who is answering today?
Sir,
Hello.
Dr. Hamid Soleraj and Samit Doshi.
One second. Dr. Rathi is answering.
Dr. Hamid
Acha, okay. Dr. Mohammad Hamid is answering, and
Soleraj Gangaram and Samit Doshi.
okay, Samit, and
Soleraj.
he has not joined.
I think, sir, he has joined. Samit has joined.
Yes,
Samit
sir.
has, Samit has joined, but Soleraj,
Haven't yet.
we just wait for 2 3 minutes. Dr. Gite will join, and then we start.
Okay, sir.
Hello, Brijesh.
Yes, sir.
Yeah, we can start the case. Who is answering? Soleraj, Hamid.
Dr. Hamid and another one doctor is it? Dr. Samit.
Okay. So, Samit, you want
Yes,
to
sir.
start?
Yes, sir.
Okay, start then.
Good evening, sir. Uh, a 57-year-old male patient from Surat presented with complaints of right flank pain on and off since 3 months.
Okay. So, what are the important questions you want to ask?
Sir, I wanted to ask first the nature of pain, along with the onset, duration, and the progression, and any associated LUTS if it is present, and any history of hematuria with the flank pain.
Hamid, you want to ask anything more? He's not there. Soleraj?
Hello, hello.
Yeah. Mohammed,
So I want
you
to
want to
I want
ask
to ask.
anything else?
Yes, sir. The intake history, then the dietary habits of the patient, then any associated LUTs, onset, duration, progression, nature, severity, aggravating, relieving factors, then associated factors like nausea, vomiting, fever, and hematuria, any history of lithuria, any history of dysuria, then other history like history of trauma, then any history of CKD like pedal edema and facial puffiness, breathlessness, dyspnea, and exertion. These history I want to ask, and apart from this, I want to ask any family history and any geographical history of the patient.
Okay. So, what is your probable when patient comes like this in your OPD? What are the differential diagnosis that comes in your mind?
So this is a 57-year-old male patient, sir. So my differential diagnosis would be urolithiasis and any renal mass, any cystic disease, and on the later in the line, it can be a PUJ or adrenal mass, sir.
Okay. Fine. So these are the four differential diagnoses you want to keep, and then urolithiasis is the first diagnosis in your mind,
Yes, sir.
and that is why you are asking all this history. Correct?
Yes, sir. Yes, sir.
What about hematuria? You ask about hematuria, fever.
Yes, sir. I have asked about hematuria, fever, nausea, vomiting, lithuria, and pyuria, and dysuria, and lower urinary tract symptoms.
Any other associated LUTS?
Okay. Maheshwari ji, want to add anything to them, and otherwise we'll go ahead.
I think we can go ahead, sir.
Okay. Fine. Brijesh, go ahead.
Patient patient was relatively asymptomatic before 3 months when he developed pain over the right flank region. The pain was colicky in nature, sudden in onset, radiating to back, gradually progressing, increased since 20 days, associated with nausea and vomiting. No specific aggravating factors, relieved on taking analgesic. So considering this history, the HOPI, before 3 months, he had a similar pain that was sudden in onset and colicky nature, which was radiating to the back. And now, since 20 days, it has been progressing and increasing and associated with nausea and vomiting. So suspected that there could be it looks like a ureteric colic. So it could be any ureteric stone.
I would suggest don't be so specific in saying it's a ureteric stone. say that my most probable diagnosis is
Most probably.
right-sided obstructive uropathy related to urolithiasis.
Okay, sir.
Okay. So because you see, the nature of pain, whether it's a renal stone or a ureteric stone, and further based on which place the stone is in the ureter, the radiation and everything would be different.
Yes.
So let's not get into that part of history. So based on this, I persist with my differential diagnosis. Obstructive uropathy probably related to stone.
Stone disease.
What else? How do you proceed further?
Yeah, and Maheshwari ji, I agree with you. Second important thing is if you say so specifically, then the examiner feels that you know the case. And
Absolutely.
so, be whatever Dr. Maheshwari has said, say accordingly. Okay?
Okay, sir.
Okay, fine. So, Brijesh, go ahead.
No history of fever, burning, micturition, or any discharge. No history of hematuria. No history of any catheterization or instrumentation. No history of facial puffiness, exertional breathlessness, lower limb edema. No history of jaundice, headache, or backache. No history of bleeding disorders, anticoagulant therapy, or blood transfusion. So this pain is not accompanied with any hematuria, fever, burning, micturition, or any CKD features, or there is no history of any past catheterization or instrumentation.
Okay. Please proceed.
Sir, one question, Mike. Should we ask the history of catheterization in the patient with the flank pain?
In this young patient, I don't think, because if there is no history of any surgery or no history of any retention, why you want to ask about the catheterization?
And
Any
same for the
instrumentation, yes.
jaundice.
Pardon?
Same for the like jaundice and
So jaundice and
catheterization and
all,
jaundice.
this is to complete your history, you can say, and because of course the chances of malignancies are very less, but still that is one of the probable diagnoses which you are putting. So you just to complete your history, you can say that.
Sir, and any other history of LUTS is also not mentioned, like any frequency, urgency, or any irritative symptoms.
How is your stone diagnosis related to LUTS?
Sir, if it could be a lower ureteric stone,
Okay,
then
so
it could
more likely
suspect.
to be a juxtavesical stone or an intramural stone in the intramural ureter.
Yes, sir.
That could lead to vesical irritation and more of storage symptoms.
Storage symptoms.
ठीक है जी, चलिए, let's move forward.
No history of hypertension, diabetes, tuberculosis, hypothyroidism, no allergies. Family history is not significant.
Please proceed. So this
Personal
is all
history.
normal.
Yes.
Let's proceed further.
So personal history diet is patient consumes mixed diet, normal appetite, bowel regular and normal. Bladder is regular, normal, sleep pattern normal, no addictions, non-alcoholic, non-smoker.
Okay, so based on this, our differential diagnosis remains same.
Yes, sir.
Please move forward.
Uh, So on general examination, patient is conscious, cooperative, well oriented to time, place, and person. weight of 84 kg, 175 centimeter is the
Samit,
height.
please don't read everything.
Okay,
You read and give one line conclusion.
Okay, so the general examination appears to be normal, and head to toe and spine examination is normal, and the external genitalia local examination is normal. So on per abdomen examination, it is normal.
So you see, when instead of saying normal, what you should be doing is you should say what is important that you have specifically looked at.
Especially, yes.
So in general examination, I would say general examination is normal. There is no anemia, there is no hypertension. On abdominal examination is normal. There is no renal tenderness or palpable kidney.
So no swelling. Yes.
Yes. So give a specific answer and move ahead.
Okay.
So this way the examiner would know what all you have looked for.
Yes. So on palpation, there's no tenderness, and the no obvious palpable lump or bladder is palpable. And on percussion, this abdomen is tympanic, and auscultation bowel sounds are heard. And the rest systemic examination appears to be unremarkable. And on DRE, there is a grade 2 enlarged form prostate with mobile rectal mucosa and normal anal tone.
ठीक है जी. Any change in your differential diagnosis?
No, sir.
So how do you want to proceed now?
So after considering to summarize, the patient having 57-year-old with right flank pain, with only positive without any LUTS and any other negative history. And so I would like to proceed ahead further with blood investigations, including a CBC, creatinine, urine routine, and along with ultrasonography of KUB. So when the blood and the urine reports, only alarming is the creatinine is high, it's 1.5. The rest all labs are
So
normal.
again, don't call this alarming.
It is high.
So the way I would say this is, in the baseline pathological evaluation, creatinine is marginally elevated, rest everything is normal.
Normal.
Chaliye.
The urine routine is also normal, sir.
So urine routine does not show any hematopyuria.
Hematopyuria.
Sonography दिखाएं.
All of you now, please, whatever Dr. Pankaj is saying, now please learn it and keep it by heart, because this is the way you have to excel in exam.
Okay, who is reading the sonography?
Amit, you can also answer, huh?
Yes, sir. So this is the ultrasound of KUB region. One of the kidney shows hydronephrosis with normal parenchymal thickness, with the corticomedullary differentiation is maintained on the hydronephrotic kidney and the other kidney as well. Though no no echogenic shadow is seen in both of the kidneys, and the bladder looks normal. It is partially distended, and the bladder wall thickness appears normal.
Hamid, if you can look at the second row, the
Yes,
first
sir.
and
Yes.
second image,
Pelvic.
what do you find there?
There is an
In second of image, there is a posterior acoustic shadow.
So you said there is no stone.
So I missed it, sir. Sorry.
Please don't do this. And again, why are you saying one of the kidney? In the image below that, you can see LK. So the left kidney is normal, we know that. So this is obviously right.
Yes.
You also know that patient has presented with right flank pain.
Yes, sir.
So again, sonography of KUB shows left kidney to be normal. Right kidney appears normal shape, cortical thickness is maintained. There is a large hyperechoic shadow in the mid pole of kidney with significant post-acoustic shadow. I would not comment on hydronephrosis. I have not seen hydronephrosis anywhere. Where do you see hydronephrosis?
In I felt like in the second row on the left side, a bit off.
Anyway, no
So,
problems.
so
So
can the
let's not
patient come
overread
with
sonography. But you see, still missing such obvious stones would not be acceptable.
Yes, sir.
can the patient come with right flank pain and still have a left renal calculation?
Yes, sir. That can be a possibility.
How what sonography is normal?
Yeah. So Hamid, next what you want to do?
Sir, I would like to further investigate this patient.
So what you want to do?
Non-contrast CT scan, CT urography I want to do in this patient, sir.
But creatinine is high.
But creatinine is marginally raised. So I would like to hydrate this patient.
Okay. You want to hydrate this patient and
Yes.
repeat the creatinine.
Yes, repeat the creatinine. If the creatinine is normal,
So
then I would
okay.
like to
So
do
there are two scenarios. Suppose the creatinine is still high. Then what you will do? And if the creatinine is not high, what you will do?
Sir, if the creatinine is normal, then I would like to do a CT urography. If the creatinine does not come down to the normal value, then I will proceed with the non-contrast CT scan of the cave page.
Amit, hold on. We are in a problem here. Now tell me, how do you hydrate and when do you repeat a creatinine? And how often have you done this, hydrated and repeated creatinine to see that creatinine has come down?
Less time, sir. Not in the routine practice.
So
Routinely,
then why are you saying this?
I would directly go with the non-contrast CT scan, sir.
Please don't make such comments, because you know what you were trying to say and what you have said are completely different. In a patient with borderline elevated creatinine, if you want to do a contrast study, you should hydrate the patient before contrast study. That does not mean that hydration will reduce creatinine.
Yes, sir.
You understood the difference between these two things?
Yes, sir. Yes, sir.
सो ऐसे कमेंट्स ना करें कि हाइड्रेट करके क्रिएटिनिन चेक करेंगे और नॉर्मल है तो ये करेंगे, एबनॉर्मल है तो वो करेंगे.
Okay, sir.
चलिए, now why do you want a contrast study?
Sir, ask them why they are hydrating the patient.
Please go ahead. Why do you want to hydrate?
Sir, on this ultrasonography, both kidneys are looking normal with the normal parenchymal thickness, and and this corticomedullary differentiation is maintained. So dehydration may be one cause of marginally raised creatinine.
No,
Or
that was your first
like-
scenario. Sir just made it clear that we are not hydrating because he's dehydrated.
You see, dehydration patient would present with vomiting, fever,
Correct.
okay, loose motions. Do you have any of this history in your presentation?
No, sir.
Sir just made it clear to you now that we are hydrating. Why? Because the creatinine is marginally raised and you still want to do a CT. So in that case, why are you hydrating?
how does hydration help in giving contrast? Let me be more specific in the question.
Sir, to avoid the contrast-induced nephropathy, one of a precautionary measure is hydrating the patient. On that basis, I thought.
Okay, Chali, I would suggest read this, read about precautions to be taken before doing a contrast study. This is a very debatable issue. Conventionally, we hydrate the patient, but there is ample literature which says that this really does not make much difference. Okay, but I would suggest read about this and make your own impression on this. Maybe discuss with your radiologist as to what is the your institutional protocol and give that as an answer.
Yes, sir.
Now, coming back to my question, Hamid, why have you asked for a contrast CT and not NCCT?
So, in this film, on this ultrasound images, the right kidney is showing one echogenic shadow with posterior acoustic enhancement. Probably it is a renal stone or the pelvic stone. And the contrast CT I want to do for the functional and as well as the anatomical study that will help in determining the stone size, stone Hounsfield unit, stone location and number, as well as the parenchymal thickness. It will help in determining the anatomy of the kidney. That will help in the treatment planning. And apart from that, the contrast enhancement will show me that will give an idea of the functional status of the kidney as well.
Okay. So I could debate this further. You said number, size, site, HU. None of these needs a contrast study. You said anatomical details with say 64 or 128 slice CT. NCCT can give you a good amount of anatomical details. Last question is, does contrast CT tell you about the function of the kidney?
Contrast CT as such does not tell about the functional status of the kidney, but when there is a contrast enhancement, there is around 20 to 30 ml per minute of GFR of the kidney. So on that basis,
Give me a reference for this comment.
Okay. I'll at present, sir, I have no reference, but I have read somewhere. So yeah.
So Hamid, what you are saying applies to intravenous urography. When you do a IVU and IVU shows a nephrogram, they say that the minimum percentage function of that kidney is around 30%. The opacification that you see on contrast CT only talks of vascularity, it does not talk of function. Even in kidneys which are very poorly functioning, you look at any say huge hydronephrotic kidney and the parenchyma may still opacify. So contrast in CT does not show function, it shows only vascularity. Anyway, still I would suggest that though most people in practice would do a NCCT, in exam it would be safer to talk about contrast CT because a lot of examiners would like to listen about contrast CT. What have we done? Please show the images.
Yeah. Second thing is, I agree with you, but second thing is that whenever we are doing PCNM, you want to know about the status of the opposite kidney also. So either you do DTP or renal scan, because by chance, if you come across bleeding and if you have to do an nephrectomy, you should know the status of the opposite kidney. Or for that matter, it is always so. You can do contrast CT. It is, as Dr. Maheshwari said, it is a better answer whenever it is possible. Otherwise, you can always say that, sir, for the function, I will go and do the DTPN.
Okay.
Acha, can you see in this sonography, can you see something in the bladder also? Or bladder is absolutely normal? Right lower pills,
Right.
see?
Yes, sir. On the right lateral wall, there is some echogenic shadow is there, sir.
Shadow.
Yeah. Correct?
Yes, sir.
Okay. So in all the probability, what is his age?
57.
57.
And what about, can you comment anything on the prostate? Is there any, can you comment on the prostate also? Okay. Anyway, just see the report. Brijesh.
Right kidney measures 11.6 cross 5.1 centimeter, multiple calculi, largest of 15 mm in the mid and 14 mm in the lower calyx, mild hydronephrosis, secondary to 15 mm calculus in the pelvis. Left kidney shows a calculus measuring 6 mm in the upper calyx. No evidence of hydronephrosis. Bladder, well distended, pre-void 94, post-void 21 cc. Prostate grossly enlarged, approximately 51 grams. Opacity measuring 12 mm seen in urinary bladder at the junction of prostatic urethra may represent a prostatic urethral calc. So right-sided mild hydronephrosis with large calc suggested to rule to do KUB, rule out and stagon calculus. Gross prostatomegaly and 12 mm calculus in prostatic urethra.
Can you please go back and show the prostatic urethra again? Yes, in the middle shadow, you can see the postogastric shadow and the hyperechoic shadow. Good. Though clinically, probably he did not have any lower urine tract obstructive symptoms. Okay, what next now?
Now again, Mohammed and Samit. Again,
Yes.
see this report. Now tell us what are the total different investigations you like to do.
So based on the sonography report, I would like to do CT IVU, but the creatinine is high. So,
So Samit, suppose the creatinine is high.
yes, sir.
Okay. Still, can you do CT IVP or it is absolutely contraindicated?
Uh, so we can
Will
do.
you-
This is it's the creatinine here is marginally raised. So
So what is more important, creatinine or
the clearance, the GFR.
GFR? So suppose at what GFR, even if the creatinine is high, till what GFR you can do IVP or urography? Yes, anyone can answer. Hamid? Paras? I mean, Swastik, you are there, you can answer. Okay, let's go ahead.
You see, let me just give you this answer. If you calculate the overall GFR to be more than 60, then doing contrast CT is absolutely safe. It is only when the GFR is less than 30 that the risk significantly increases. In these patients, you could use non-osmolar contrast. Then you could hydrate the patient. There is some place for N-acetylcysteine. And most importantly, post-contrast study, you should monitor the patient with hydration, observe for any rise in creatinine. So if clinically indicated and if it is important for your treatment, then giving contrast is acceptable. So you weigh between the advantages and disadvantages of giving contrast. Now, in a patient with stone disease, more often than not, giving contrast is not going to change your treatment too much, because even if you don't get the perfect anatomical details, you can get them once you plan treatment by a retrograde parallelogram or by other means. So if there is borderline raised creatinine, don't get into this controversy. Just get a NCCT done, get the stone information and plan the treatment. Was I audible or?
Yes,
Yes,
okay.
Yeah.
Okay.
sometimes in doubtful cases, it's very much essential to do a urography. So
Yes.
in those situations, if you justify it, you are very well, examiner will understand. So I'll give you one small example. There was a patient referred to me and had undergone left URS with and continued to have left flank pain. And when we asked the patient what happened during the procedure, they said that, sir, doctor said that he did not find the stone inside.
See,
And then this patient I had called sir also, Gaurang Shah sir had also come, because it turned out to be I repeated a CT and patient had complete duplication, and they'd done URS in the wrong ureter, and there was a stone in the other ureter. Sir, you remember that patient?
yes, we remember.
Yeah. So in special situations, you can justify it. You know, if something like this, that it's a redo case or you're suspecting some abnormal anatomy. Like last class, we saw horseshoe kidney. Those kind of situations, you're justified also. Like Maheshwari sir said that many examiners want to hear CT urography. Otherwise, if it is a simple case and you say NCCT, KUB, also it should be okay.
So just remember, GFR is more important, and I think 55 or 60 GFR is the till that time you can do IVU, but still confirm it and let us know. Okay, fine.
But in majority cases, CT urography is ideal answer in exam. Until and otherwise, it is a very small stone in lower ureter. Then non-contrast CT scan doesn't show any doesn't give any clue of complexity. Then okay.
Absolutely agree,
But
sir.
whenever you feel it is necessary, it is better to tell CT urography.
Absolutely.
As sir told कि majority examiner expect CT urography because जसं आता अभी एग्जांपल बताया कि दूसरे यूरेटर में स्टोन है, वो तो नॉन कॉन्ट्रास्ट सिटी भी अगर अच्छा रिकंस्ट्रक्शन किया तो
Yes,
पता
sir.
चलता है, नहीं चलता है
Yes,
ऐसा
sir.
नहीं है. लेकिन वो एनाटॉमिकल रोड में आप और एक ट्रेडिशनली सब कुछ कैलासिस किधर है, कौन से कैलिक्स में कितने स्टोन है, कैलिक्स क्लोज है, बंद है, ये सब चीजें बहुत बार नॉन कॉन्ट्रास्ट सिटी स्कैन में अगर अच्छा रेडियोलॉजिस्ट नहीं है तो मिस हो सकती है.
Yes,
दैट्स
sir.
व्हाई कॉन्ट्रास्ट सिटी स्कैन अगर बोला तो गलत नहीं है. अगर नॉन कॉन्ट्रास्ट बोलना है और उसको डिफेंड करना है तो स्टोन कहाँ पे है, कितने साइज का है, और वो सिंपल है नहीं है, प्रोक्सिमल हाइड्रोनेफ्रोसिस कितना ज्यादा है कम है, सब कुछ देख के डिसाइड करना है एग्जाम में क्या आंसर देना है. दैट्स व्हाट.
Correct. So as Dr. Gite said, for example, if there is a ureteric calculus, okay, and it is a small ureteric calculus, and otherwise the creatinine everything is normal. Sonography is saying parenchyma is normal. There is hardly any hydronephrosis, mild hydronephrosis. In all these situations, you can just escape saying it is non-contrast. Otherwise, if you are in doubt and you want to do some intervention in the kidney, that is PCNF, it is always advisable to say contrast enhanced CT urography. Okay, fine.
Yes.
So, okay, Samit, just tell us which are the other investigation you want to do. Patient had got some, now you know that there is a stone in the pelvis, in the prostatic urethra. Also, patient has got probably a big stone in the kidney, and he is a
Yes.
55 years old. So, tell us what are the things you want to do.
So, so after after the CT you're asking, sir?
So, you want to do CT, number one. You want to do
Yes.
non-contrast or contrast CT?
So urography,
Okay.
contrast CT.
Provided his GFR is more than 60, correct?
Yes, sir.
Okay. And if you can't do contrast CT, then what along with that you want to do anything else?
Then NCCT KUB, sir.
Okay. Along with that, anything else you want to do?
So along with then even an X-ray KUB.
Okay. Anything else?
Because and so radiologically only these two main investigations, sir.
Anything else? Nothing? Okay, Bridges, just show him what are the things you have done. One after another. Show the pelvic X-ray. Okay, these two X-rays. Hamid, can you tell us what are the findings? Samit, you can tell us.
So this is in the this is a pelvic X-ray uh, with there is a radio opaque shadow which is seen along the course of the urethra, and it is in the uh, pros- prostatic region with
Where you have seen that radio opaque shadow in prostatic urethra? Where prostatic urethra starts?
at the
सुपीरियर बॉर्डर ऑफ सिंपैसिस प्यूबिस, इंफीरियर बॉर्डर ऑफ सिंपैसिस प्यूबिस, बीच में रास्ते में कहाँ स्टोन दिख रहा है तुमको?
no, so that
It is absolutely inside the pelvis, na, that radio opaque shadow.
it's in the
See, if you want, you can say at the thing,
pelvis that
urethral junction, near
vesicle
that,
has. Yes.
you know,
Sir,
but don't say in the prostatic urethra.
Sir, identifying radiologically vesico-urethral junction is difficult, number one.
Difficult, correct.
Number two, that radio opaque shadow is absolutely overlying the some sacral terminal phase of the sacrum, terminal part of the sacrum, and it is away from the symphysial joint. So, most probable chance that stone is, if it is trilobar prostate, behind the median lobe or inside the bladder only, as far as my reading is concerned.
Every time I'm telling you,
I would agree with sir that there is no way you can call this prostatic urethral stone.
Yeah.
To call it prostatic urethral stone, it should be seen in between the radiolucency of the pubic symphysis.
Complete. I agree. Sir.
If you look carefully, you can see the bladder silhouette. You can see the bladder outline.
Yes,
Just
sir.
above the pubic symphysis, and the stone is above that. So how can it be in the urethra?
and while describing X-rays, you should not comment on this is there and this is that. I think you should read the X-ray every time we are telling you to say X-ray KUB, well prepared, centralized, bony architecture. There is a radio opaque density seen in the pelvic region. Most probably, sir, it is a vesicle calculus or whatever you want to say, urethral calculus, but I would like to confirm further. If you say that, you are safe, no? Rather than
Okay, sir.
commenting on prostatic urethral calculus. So much discussion happened. It's just better to read the X-ray and say that I would like to confirm by doing whatever you want to do further.
देखो simplified X-ray pelvis with both hip joint, ill prepared, lot of gaseous shadow in the pelvic area, bony shadows looks normal. Then there is radiopaque shadow in the area of the bladder, approximately size जो भी बोलना है बोल दो. Along the prostatic urethra, no any radiopaque shadow, and distal to the in the bulbar area or bulbar urethra. Visualized area, visualized perineal area or bulbar urethra, no any radiopaque shadow. See,
Okay, sir.
so इतना क्लियर बोलना है क्योंकि अननेसेसरी कंफ्यूजन हो जाएगा. फिर वो प्रोस्टेटिक क्यों नहीं है, प्रोस्टेटिक है, वो अपना एनाटॉमी में ही गड़बड़ कर दिया तो थोड़ा सा बैड इंप्रेशन पड़ता है.
One more point which you should add is that you can say that the radiopaque density is in the midline. The moment
Exactly.
you say in the midline, it goes in favor of bladder calculus. If it is in the intramural ureter or UVJ, it would be away from
Correct, sir.
midline.
Correct, sir. Yes, sir.
So do not diagnose this as prostatic urethral stone. This is a radiopaque, small radiopaque density in the bladder region in midline, probably vesicle calculus.
Agreed.
Okay, sir.
Okay, Samit, can you just repeat it and go ahead? Whatever
This is
doctor.
a
Yeah.
pelvic X-ray which showing the both bony shadow, and it is ill prepared with lots of there is gas shadows seen, and there is a single radio opaque density which is seen in the midline in the bladder region, approximately uh, 2 by 1 centimeter, and without any radio opaque shadow along the course of the urethra, that is in the prostatic or the bulbar urethra.
So probably this is a vesical calculus.
It's probably it is a vesical calculus, needs further evaluation.
Fine. So next, what else you want?
So the X-ray KUB films and the CT films. So this is an X-ray KUB.
Where is the bladder? Where is bladder?
It's not. It's not. So it's a abdominal X-ray, sir.
Okay.
With there are numerous gas shadows seen, and there is a radio opaque shadow which is seen in the right kidney, which occupies the upper, middle, and the lower calyx along with the pelvis, with and it's probably it's a stagon right side stagon calculus with some secondary stones which are also secondary calculus which are also seen.
Again, you said X-ray KUB and you went straight on the stone. What if patient has CA prostate and there were multiple mets in the bones? You never saw the bones only.
So the
sometimes in the exam you will get X-ray like that. Gaurang Shah sir had once put a DJ stent. Everybody was talking about DJ stent and they forgot to see the bones. Patient had metastatic CA prostate. So when you are reading any investigation, make it a habit. Na? We've just started the program. Last 2 classes we are telling you, read CT properly, read sonography properly. Last time Maheshwari sir also told you, read, tell about liver, spleen, gallbladder, pancreas, blah, blah, blah. Same way in X-ray, you tell how is it, well centralized, well prepared, how is the bony architecture, where is the exposure. So shadows are not seen in this X-ray.
Yes.
You see, Samit, make this as a habit. The moment you say it, even in 2 lines, even examiner is interested in discussing the stone, but they just want to be sure that you have looked at everything. So how you would should say about this is the abdominal film of the X-ray KUB, which shows bony architecture to be normal. Bowel preparation, you can say suboptimal in most patients. A large radiopaque density is seen occupying the right renal area. Rest of the things as you have described, probably a right Stefan stone. Now you mentioned about the secondary calculi, but then you then did not say where they were. So either I would not talk of secondary stones, but if I talk of secondary stones, then I would say secondary stones seen in the lower calyx and the middle calyx.
Middle calyx, yes.
So या तो बोलो ही मत, बोलो तो पूरा बोलो.
Yes, sir.
Okay, what next?
Yeah, sure. Brijesh, sitting. Yeah. Amit, you can answer now.
Yes, sir. So the left side films are the coronal films of CT scan of abdomen and pelvis. The right kidney parenchyma looks normal. There is the radio density uh, suggestive of the stagon calculus is present in the right kidney. Then the opposite kidney looks normal. Then the liver looks normal, and there is radio density in the area of the bladder in the midline of approx size of 1 to 2 centimeter.
What about the bladder? Can you see the bladder?
Yes, sir. The images are very small, so I couldn't. Can I get zooming images of that?
See on the right hand side bottom. Even in the
right
first film, you can see in the bottom film. Can you see that?
Yes, sir. Yes, sir. So
What is it?
there is the bladder walls looks normal. Bladder looks partially distended, and there is the calculus in the prostatovesical area.
Okay. Fine. So don't miss this. So now, Amit, I want to ask you one question. Just a wild guess. Can you now tell us why this patient had a raised creatinine looking at this? One of the reasons, because he doesn't have diabetes or any other problem which can give rise to nephropathy. So is it possible that this stone has migrated from the left side?
Yes, sir, it can be a possibility. But there is no hydroureteronephrosis. Yeah, there is no history, and there is no hydroureteronephrosis on the left side that will suggest that there is the recently passed stone from the left side, if it can be.
So you see, if you want to talk about recently passed stone, as you rightly said, there should be symptoms on that side. There should be mild hydronephrosis, and you should also see perirenal stranding. So none is there. So very unlikely that this stone has come from the left side.
Yes, sir.
Okay, fine. So now next, what you want to do?
Sir, as this is the Tagon calculus on the right side and the prostatovesical calculus, uh, and if the patient and so I want to explain the patient about his condition, what exactly he is having, and uh, what are the management option for these things. And while doing the management of these patients, what can be the complication and what is the post-operative course?
पहले क्या करना चाहते हैं वो तो बता दें.
So, sir, this is the prostatovesical calculus. So, I will at present I will explain cycle calculus. Doing the cystoscopy, removing the vesicle calculus, and then further I want to do the right sided PC analysis.
Same session, different sessions.
This can be done in the same session, but I will explain the patient that the renal stone may need multiple punctures and multi-stage.
Okay.
So how do you counsel a patient for PCNL? Just multiple punches?
No, sir, I will explain the patient what exactly he is having, and uh, this need to be this stone needs to be removed, and this is most probably there are two options that can uh, like with that I can tackle this stone in the patient either by the PCNL or the pyelolithotomy, and I would explain the patient that if I try to do the PCNL, then he may need multiple punctures or multiple sittings to remove that stone.
So I would say that any procedure, whenever you're talking to the patient, there should be some format in your mind, right? Even in the exam and even in your practice. You first need to explain the patient that there are stones, multiple stones. You also
Yes, sir.
need to explain regarding the kidney and the pelvic alveolar system. And in today's day and time, how you are going to puncture the kidney. So you talk about the procedure. So you explain the procedure in brief. You did not go into details, but in brief that we will be giving you anesthesia, turning you around. It will be done under general anesthesia. Fitness is required.
Okay,
Blood parameters have to be checked. So pre-op fitness workup, and then you will explain the procedure. Then you explain procedure related complications. You don't have to scare the patient, but you need to inform him that there can be bleeding, there can be some organ injury, there can be pleural injury, right? You may have to abandon because there is bleeding. You may need multiple punctures. It can happen that the prolonged time is there and you would like to stage the procedure. There could be requirement of higher antibiotics. There could be require of blood transfusion. Very, very rarely, 1% there is a chance of embolization. Then
yes,
you explain on post-operative recovery that there will be tubes, how you will remove the tubes, what is his expected line of stay, how you will assess him post-operatively. This is the way you counsel the patient. No? You just cannot say that I will do multiple punctures. Then tomorrow patient will say, you never told me there is going to be a tube behind. Patient will say, you
yes,
never
sir.
told me that it was going to bleed and you have stopped the procedure.
Yes,
So any procedure, make it a protocol. When examiner asks you about procedure, then you explain that this is how I'll do the procedure, this is what the expectations are, this is what the complications can be, this is what the post-operative period will be, and how you'll follow him up. It can happen that some
yes, sir.
small residual stones, you only said the secondary stone.
Yes,
Suppose it is missed, then patient may require an ancillary procedure. While removing stent, you just do a check RIRS or something like that. Or you can give lithotripsy.
yes,
All these aspects need to be discussed. When it is a long case, then you have to explain everything properly.
yes.
You mentioned that stone needs to be removed. Okay, my question to you is, why do you need to remove the stone? There is no infection, there is no renal functional deterioration. This stone probably has been there for ages. Uh, you are neither guaranteeing me complete stone removal, so why are you, doctor, removing my stone?
As per literature, if there is a staghorn calculus, then if it is not treated or tackled, then there will be a gradual loss of function. And if it is not treated, then there will be sequelae of stones, infections, and then the loss of urosepsis, and then loss of function eventually.
So the answer to this would be that this is a relatively young patient with overall good fitness. With longer follow-up, there is likelihood of all these problems happening. So it is better to get rid of the stone.
Okay, sir.
Okay. So say, okay, I am the patient, I have consented for PCNL. How will you prepare me for this PCNL?
So, sir, after taking proper anesthetic fitness and preserving adequate blood, I'll take the patient to the operation theater, give him adequate pre-op antibiotics. After, like, as per the culture,
What do you mean by pre-op antibiotics in operation theater?
like intra-op antibiotics. Intra-op, while
So
I'm
the
taking the
better
patient to
term
the
is
OTT
antibiotic, you will give appropriate antibiotic prophylaxis.
prophylaxis. Yes, sir.
Correct. I
And
would be happy with that word. You said adequate antibiotic, adequate blood. Again,
yes, sir.
discussion doesn't stop then. So you say
So
I'll
I
assess
will
his
give,
hemoglobin. If it is low, then maybe you will arrange a point or two or whatever.
yes, sir.
Or if
So
it is
I'll
nicely 14 grams, then maybe just
then
one
I'll get
whole.
a blood
Yeah,
blood grouping of the patient,
correct.
and then I'll take the patient in
And
the
like sir
OT.
said,
If
prophylactic antibiotic. Unless patient has a positive culture and then you want to prepare adequately before, then it is a different thing. But otherwise, prophylactic antibiotic should be the answer, right?
yes, sir. So I'll
So
give
let's take a
the
situation where the culture is positive and another situation where culture is negative. So when
yes, sir.
culture is positive, how will you plan my antibiotics? When culture is negative, how will you plan my antibiotics?
So if the culture is positive, I will give adequate antibiotics for 5 to 7 days to the patient to make and get a repeat culture done. If there should be no infection on the urine culture, and if the patient culture is negative or there is no growth on the culture, then I will give adequate prophylactic antibiotic to the patient, and accordingly take the patient to the operation theater.
What do you mean by adequate prophylactic antibiotic? मतलब कितने दिन पहले शुरू करोगे?
Sir, no, in the OT or in the
Okay,
OT
so you'll
only,
give a single shot before starting
single
anesthetic.
shot yes, sir. Single
Okay.
shot antibiotic. If the culture is
There
negative,
are a
and then
couple
in
of
the
Hamid small mistakes which have happened.
yes,
Whenever there is, say, culture positive, you would start the patient on appropriate sensitive antibiotics for 5 to 7 days before the procedure. But you do not need to confirm infection clearance by a culture because many a times in such large stones, it may be impossible to confirm infection clearance. So if patient is not running fever, total count is normal, CRP is normal, under proper antibiotic cover for 5 to 7 days, you can go ahead with the procedure without repeating a culture. Even if the culture is negative in this patient, because I am expecting at least a 2 or 3 track PCNL, it probably is a good idea to start oral antibiotics at least 3 to 5 days before the procedure. There is ample literature to say that antibiotics for 3 to 5 days vis-a-vis single antibiotic for a complex Stagon PCNL, the risk of bleeding and perioperative morbidity is less with 3 to 5 days of pre-PCNL antibiotics. So culture positive, definitely treat for 5 to 7 days, but you do not need to reconfirm stone infection clearance. Culture negative, maybe 3 to 5 days, depending on your institutional protocol, you would start the patient on broad spectrum oral antibiotics.
Yes, sir.
With injectable antibiotics started in the perioperative period. So AU has come up with a white paper on antibiotic prophylaxis for various urological procedures. I think it's a 5 or 6 year old document, if I remember it right, 2019 or 20 ka hai. Must read that AUA document because that gives you a very good idea about what antibiotic prophylaxis and which patients.
Okay, sir. So after giving the antibiotic and the patient, I'll place the patient in the lithotomy position, do the cystoscopy, proper cystoscopy, and remove this bladder stone. And once that stone is done, I will put the ureteric catheter and reposition the patient in the prone position. Then under the C-arm guidance and if available the ultrasound guidance, I will puncture the desired calyx. In this case, I would I would like to puncture the upper calyx, and once the puncture is done, I would like to take the urine culture again from the system, and then I would like to place the safety guide wire and dilate the tract. In this case, I would like to dilate the tract up, till 26 to 28 French, and with the help of lithoclast, I will fragment the stone and remove the stone and try to complete the stone as much as possible. And if from that puncture whole of the stone is removed, I would place the digestion and PCN. If that is if in the single puncture the stone clearance is not done completely and time allows and the patient's clinical condition allows, then I would do the another puncture and remove the residual stones or the other stones and put the nephrostomy tube and digest it.
So Amit, what
Okay.
do you expect? Is it possible to completely clear it through single puncture?
Sir, it is not like it is unlikely to do it with a single puncture.
Then why did you say that if it gets cleared through one puncture? Why did you get into that? You only said if
Okay, sir.
it gets cleared by one
Yes,
puncture,
sir.
I would do this, do
Yes, sir.
that.
Yes, sir.
So this is a patient where I would expect minimum 2, probably 3 tracts.
Yes, sir.
Okay, so you will definitely need one upper calyx tract. You will definitely need a lower calyx tract. You may need a middle calyx tract also. Or this could be a good patient to have a flexible nephroscope, or this could be a good patient to have associated ECIRS if you want to prevent the middle calyxial puncture.
Yes, sir.
So instead of saying this, if you preemptively tell me that I am expecting multiple tracks, we can do discussion on how to plan multiple tracks.
Yes, sir.
So,
So,
Hamid,
yes,
Dr. Pankaj has asked you, I told you, na, the two,
yes,
three different options he has given you.
yes, sir.
So, number one, he has said that you can do only PCNL and you can map out and you can pre-operatively, you can decide that how you are going to plan it, whether you want to do 3 punctures from the beginning, keep the guide wire, or during the surgery you want to do it, you want to enter from lower calyx, middle calyx, or upper calyx, which will be the first entry. Okay, that is number one. And second thing he said ECIRS, correct? What will be your choice?
Yes, sir. Sir, I would like to puncture the upper calyx first. Try
No,
to
I want to give you I want to give you a choice to you and to Sami. Number one, you will do multiple puncture PCNL. If you miss any stone, you will do a relook. So you will do only PCNL. Number two, you will do PCNL. If any small stone is left behind, At the time of removal of the digestion, you will do RIRS and will tackle that stone. Third, PCIRS along with this PCNL. What is your choice?
But like I can every option can be done, sir. I would personally
No,
go with
what you will like to do. You
yes,
give me
I
one
would.
option and you tell me the reason why you want to do that.
Sir, I would like to do the PCNL in one sitting, try to remove as much as stones. And if any fragments are remaining, I would like to do with the RIRS while removing the digestion, sir.
Okay, Samit, what is your choice? What you want to do? Hello?
Sir, it's the second option only. The PCNL and try to remove whatever it is possible. And at the time of stent removal, if there are any residual
No, but the
fragments,
large amount of, suppose 1.5 or 2 centimeter stone is left behind. Still you want to do RIRS at the time of removal of the digestion, or you want to do 2 sitting?
Can you get back to the X-ray KUB image?
Yeah. Bridges, X-ray KUB दिखा भाई.
Now you see, if you come from upper calyx, you will be able to get the upper calyx infundibulum and part of renal pelvis. You will definitely not get the large lower calyx infundibulum and multiple lower calyx stones. You will definitely not get the middle calyx stone. So amount of stone that you will leave behind is not appropriate for RIRS at the time of stent removal. Do you agree with me?
Yes.
yes, sir.
Okay, so then how should we plan PCNL in this patient?
Multiple punctures, sir.
So the best answer here would be that I would pre-place multiple wires in the upper, lower and middle calyx. Dilate one of the tracts. You could choose either the upper or lower calyx to dilate. And based on how much stone you can remove through that tract, you decide about dilating the other tracts. Okay. इट इज नॉट पॉसिबल कि हमारा कोई ऐसे 5-7 मिलीमीटर का पीस छूट गया जो हम RIRS के वक्त निकाल दें. If you make only single tract, you will just remove probably 40% of the stone and 60% will remain behind.
Hmm.
So, Samit, now you're
Yes,
doing
sir.
PCNL. What will be the tract dilatation? How much you will dilate?
Till 26 or 28 French.
No, Samit, don't give this answer. Tell me what decides the tract size. How will you
So
decide how much tract to make?
so depending upon the stone burden and
Okay,
Does it
one number
depend on the
stone
stone
burden,
burden?
length of the
second,
infundibulum
and the width.
Most
and width
important is the width of the infundibulum, not
width
the
width of the
length or the stone burden.
width of the infundibulum.
So if you can see, the upper calyxial width is reasonably big. So, and
Yes, sir.
because the stone bulk is high, you could make a larger tract in this patient.
Yes, sir.
Now you spoke about making a 28 French tract. How do you make a 28 French tract?
And with uh, gradually with sir Elkin's metal dilator and
So what
then
is the size of Elkin's dilators?
It should be on the tip of your tongue. If someone asks in your sleep, also you should tell.
Elkin's dilators go up by 3 French.
3 French.
Every 3 French.
So Elkin's dilator will be 27. So how do you make a 28 French tract now?
So on the dilator, what you are going to put? Yeah, Samit. Samit, on the dilator, you are going to put something or directly scope?
So we put the implant sheath and then the scope.
So implant will be of 27 or it will be bigger than that.
So it will be bigger than that.
So then how do you
Fine.
place the 28 implant sheath over 27 Elkins? Wait, Samit, are you aware of any dilators which come in even size?
Which are the other dilators? Which has a difference of 2. Like your ureteric dilators, no? You go to 6, 7, 8, then 12, 14. Same as the implant
शांति
dilator.
क्यों है भाई? मुझे शोले का डायलॉग याद आ रहा है.
Try to cook something.
Hamid, you can answer.
So the
Yes, sir. Implant dilator, sir.
implant.
Pardon? Implant dilator, correct.
So you will dilate
Fine.
till 27 French, remove the Elkins dilators, over the guide rod put a 28 implant dilator, and over that place a 28 implant sheath if you want to do a 28 dilatation. Why should this have been so difficult?
Yeah. So probably you should say that in upper and mid lower calyx, the infundibulum is little dilated. After injecting that contrast, I will see and I can dilate up to 28. And middle calyx, depending on the contrast, you will decide. Because the stone burden is also not much. You can do the less dilatation also. Correct?
Yes.
Fine. So now you have done puncture, you dilated the tract, you have finished your surgery. How will you confirm that you removed all the stones?
Sir, we can do an RGP and then see if there are any stones which are left or any like by
So from where
filling this.
you will put the dye? From where you will put the contrast?
Sir, antegrade through the
No, you got a ureteric catheter. No? You will put through ureteric catheter, correct?
the retrograde and through the urethric cut.
Okay, but what you will do to the implant? But as soon
So
as you
we will.
inject, the contrast will come out.
Tell me, why do you need contrast? This is a radiopaque stone.
Yeah, and on the Siam shoot, the X-ray, the Siam shoot will also
So number one,
help us
a
to.
visual. So number one, you are going to do nephroscopy and we try to see all around because you have made the 3 punctures. So most of the calyx you can cover. But there are chances that some minor calyx you may not be able to see. So second is by doing the Siam. Under Siam, you will check whether there is any radio opaque density is seen or not. After that, what else you can do? What you are saying is retrograde because with the small fragment may not be seen, right?
Yes.
So because the fragment may be like superficial, just the cheap, and if the house fill unit may be less, and you may not be able to see under Siam. Second thing is our Siam is not as good as the X-ray machine. So that is why you may not be able to see all these small fragments. So you like to do RGP and find out whether there is any radiolucent area is seen or not. But before
Yes.
that, you must block your implant.
Block the implant sheet so that the contrast.
Okay. So now you have confirmed all these things and you are putting nephrostomy,
Yes.
right? When you will remove the nephrostomy, will you like to do any other investigation before removal?
Sir, we can do an like before removal, obtain an X-ray KUB
Okay.
to find out if there is any stone fragment left, and see if any further second stage if it is required or not.
So you like to do sonography, X-ray or CT? What is recommended? In the Stagon calculus, when you are doing the multiple puncture, what is recommended? Just to do X-ray, sonography or CT?
So then do a CT.
Yes, it is recommended. And second thing is, even second look is recommended. Means
Yes.
if just such a stone is there, then before removal again you can put an implant and you can see whether any small fragment is left behind the clot, and you can remove all this.
Yes.
Pankaj bhai, please
Yes, sir.
correct me if I am.
No, sir, absolutely right. So if you are going to do a CT scan, and if CT scan is clear, probably check nephroscopy is not needed. Check nephroscopy was a standard of treatment when routine CT scans were not done for stone disease, because small stones could be missed on a X-ray KUB or ultrasonography. So if you have facility for CT scan, get a CT scan done. If no facility, then a X-ray KUB followed by a check nephroscopy.
Yes.
In this patient, the puncture he told, I am not happy with the upper callosial puncture in this patient. Because if you puncture the upper calyx, you may not reach to the lower calyx, the lateral most part, and middle calyx lateral most part. So you can clear only the pelvic area. Okay. So if you puncture the lower calyx and middle calyx, both puncture, and start with lower calyx, because the infundibulum is width is more. Then you can, after fragmenting some stone, you can park your ampullage inside the lower calyx, and at least you can clear the lower calyx completely as well as the pelvic area. If the kidney is pliable, then you can reach some part of the middle calyx. If some fragments, lateral most fragments in the middle calyx remain, that can be punctured or dilated over that wire, or give a flush, and that stone can come in the pelvis. So chances
Yes.
of getting a maximum clearance with starting the puncture of lower calyx is more in this patient. And obviously, as sir told, you can have a wire in the middle calyx also. So probably with two puncture, majority clearance will be done. Lateral most, some blind part of the calyx, small stones may remain there, that cannot be accessed by upper calyx also. So puncture should be ideal. What is the ideal puncture? What are the types of puncture? Then length of the infundibulum, width of the infundibulum, infundopelvic angle, ये सब चीजें टिप ऑफ टंग पे रहना चाहिए. ये प्रोसीजर ऐसी है कि एक तो इंस्ट्रूमेंट में भी आएगी, या स्टोन का अगर कोई पेशेंट है वार्ड राउंड में भी आएंगी, या फिर लॉन्ग केस में भी आ सकती है. तो ये प्रोसीजर में कंफ्यूजन में कोई स्कोप ही नहीं है. ऑल टाइप ऑफ द डायलेटर्स, हर एक के नाम पता रहना चाहिए. क्यों 26 तक कन्वेंशनल पीसीएनएल का जो हर स्टेप टिप ऑफ टंग रहना चाहिए. तुमको माइक्रो पीसीएनएल, मिनी पीसीएनएल नहीं आया तो चले, लेकिन ये इसमें कंफ्यूजन नहीं रहना चाहिए.
Yes.
Fine. So after you confirm that there is no stone left behind, that is number one. Number two, only 5 millimeter or 7 millimeter calculus is left behind, and then you don't want to do a next puncture. Now, when you will remove the nephrostomy, and when you will remove the Foley's catheter. Yes, Samit.
The nephrostomy on the day 2
Hmm.
and Foley's catheter on the day 3.
Okay. So when if it is not there is no socket, then you like to remove the Foley's catheter. Correct?
Foley's catheter, yes.
Samit, again,
Now,
not happy with the answer. Don't say day 2 or day 3. Tell about the clinical factors which will decide when you remove the nephrostomy tube. Suppose day 2 he is still having hematuria. Will you remove the nephrostomy tube?
No, sir.
So you will have to say that when the
So there is
patient
no
is
bleeding.
exactly. So it is not the day which is important, it is the clinical picture which is important.
If the patient is stable and there is no bleeding, then we'll remove on it. But if still there is persistent bleeding, then I would like to keep the nephrostomy tube till the bleeding subsides.
So your nephrostomy tube will be decided by how much residue you have, whether you are planning to do
Another
a
sitting.
second stage nephroscopy, whether there is any bleeding, whether the patient is clinically stable, means no signs of sepsis infection. It will also be decided based on what intraoperative problems you had, whether there was any calacial injury, whether there was any renal pelvic injury. So इसलिए कोई ऐसे ब्लैंकेट डे 2 डे 3 की बात मत कीजिए.
Yes.
so you can always say, and as Dr. Pankaj Maheshwari has said very rightly, yes, sir, if there is no complication, clinically patient is absolutely fine, no fever, no hematuria, no bleeding from the thing, the X-ray and CT scan is not showing any residual calculus, then on second or third day I will remove the nephrostomy. Okay, and once after removal of the nephrostomy, if there is no leakage from the nephrostomy side, after that, why you want to remove catheter after that? Some
इसमें
people
क्या है,
remove the catheter before.
in spite of telling the days, I also agree with Pankaj sir, when urine get clear at that time, and if there is no any indication to keep the patient further, I will remove the patient.
Fine.
तो एक क्वेश्चन
Okay.
क्रिएट हो जाता है, वो फिर व्हाट आर द इंडिकेशंस पूछते हैं, तो सर ने जो बताया था वो एक आंसर और एक क्वेश्चन अपने तरफ से पॉजिटिव हो जाता है. तो यू शुड गाइड द एग्जामिनर इन स्पाइट ऑफ आस्किंग, गिविंग द चांस टू एग्जामिनर.
Okay, so Hamid, now you remove the Foley's catheter and patient comes with the socket and there is a fluid urine coming out from the nephrostomy. What you will do now? Yes, Hamid.
Sir, can you repeat the question, please?
Yeah, you have removed the nephrostomy, everything was fine, there is no fever, there was no pain, okay, there was no bleeding, and
Yes, sir.
after that, you have removed the Foley's catheter.
Yes, sir.
Now patient comes back to you saying that there is a leakage of urine from the nephrostomy side.
Yes, sir.
Now what you will do?
So I'll again place the Foley's catheter in this patient and keep for a period of 1 week, sir. Or according to the dryness of the patient.
Now,
And if
my
needed,
question is,
I'll start. If needed, I
what
will
are the
start.
causes? What are the causes of this leakage?
One may, if the patient bladder is distended and there is retrograde flow of the urine from the bladder to the system through the digestion or across around the digestion.
Okay, one. Second,
due to the spasm of the bladder. Sir.
so that you said from the spasm, the fluid is going back. Second,
the like I have like if the DJ stent is not placed properly, sir, that may be a cause.
You never asked for X-ray KUB.
I will, yeah, I was about to ask that if the X-ray KV is normal, if it is not normal, or like there is a
No, I
possibility that
agree.
the degenerative is okay.
No, I agree with you. So now you have asked for the X-ray KUB. In that, what are the things you like to see?
The upper end of the digestant, is it properly coiled or not? And if it is not coiled, where
Why
exactly
only
it is
upper?
placed?
Why only upper? Why not lower?
And lower, sir. Upper and the
No,
lower.
see, so answer properly. No? You want to see the digestant is properly placed. Correct?
Yes.
One. Second,
The bladder distended, sir.
no, that you already said. Second, want to see any
Anything else you will
radiopaque?
see on X-ray QUB? What else you will see on X-ray QUB? You asked for the X-ray QUB, no?
Yes, sir.
Anything in the track?
Yes, anything in the track, sir. Yeah. So
There may be a small fragment in the ureter.
that, yes,
That
sir,
also
that can
can
be
give
there.
rise. No? Third,
If the
even the
yes.
infection can give rise. No? So now how will you manage this case?
If the resistant is placed properly, then I would like to place the catheter and continue the patient on anticholinergic. If the resistant is not placed properly, then I will would like to reposition the resistant. And if there is a fragment that might be a cause of that, then I will remove the fragment and reposition the stent. And if there is an infection, yes, these are yes, sir.
Maheshwari sir, please explain that.
Yes, sir, fair. This is a fair answer. So the causes for persistent leak would, as you rightly said, would be bladder spasms, improperly positioned stent, and bladder outlet obstruction. So because of bladder outlet obstruction, if patient exerts more to empty his bladder, that also could be one of the important reasons for reflux. So the best way to treat that would be by placing a urethral catheter and giving agents which lower the bladder pressure. That means the anticholinergic drugs. Okay, there could be other things which you could do is ask the patient to reduce the fluid intake, keep that side of the kidney in a non-dependent position, give some compression dressing. Usually most of these leaks would stabilize with time. If there are features of infection, you would cover this patient with antibiotics.
Yes, sir.
Yeah. And if that stent is not properly placed, you will replace it. And if there is any small fragment, only with the medical management, you can see that it comes out. No need to again go and do the URS. Unless and until the leak is continuing and patient has got fever or any other complication, then you may go inside and remove the stone immediately. Right?
So more often when we are talking of these stones, these are not stones in the ureter, because ureter you have deobstructed by a stent. These are usually stones in the infundibulum and the stent is in the renal pelvis. So one of the calyx gets say cut off because of the obstructing stone in the infundibulum, and that leads to a prolonged leak.
Fine. Okay. So now this patient, Hamid, on the second day, patient has a hematuria. Now what you will do? You have not removed the nephrostomy. Now patient develops hematuria. Hamid, you are there? Hamid?
Hello.
Yeah, Hamid.
So I would like to see the cause of the hematuria. Is it because of the digestion? or the infection, sir. So, and is it like it mild hematuria or is it gross hematuria?
Okay. So if it is a mild hematuria, what you will do? If it is a gross hematuria, what you will do?
So if it is a mild hematuria, then it's probably due to the stent. So I will counsel the patient about it and start the anticholinergics. And if it is gross hematuria, then I would like to uh, see the vitals of the patient. If the vitals of the patients are normal, I would like to see the cause of this hematuria post PCN also.
So what you will do?
If the patient is like if there is any signs of vital instability, then I would do the CT angiography
Okay,
in
this
this patient.
patient after 48 hours, patient had a gross hematuria and developed retention, clot retention. And when we did the CDC, the post-operatively from 13 it had become 11 and now it is 7.
So, sir, probably due to the it's more probably due to the source, more probably due to the kidney. I would like to do the CT angiogram and see where is the cause of the hematuria, and accordingly I will take the patient if needed for the angioembolization.
Why you want to do CTI? I mean CT angio.
Conventional angiography, sir.
So if he is bleeding and you want to do, then do conventional and at the same time you do embolization.
Yes.
So what is aneurysm and what is malformation? AV malformation and aneurysm.
So aneurysm is the dilatation of dilatation of the and collection of the the AV malformation is the abnormal connection between the vasculature of the kidney, and the aneurysm is the
Vasculature of kidney
weak
means what?
artery and vein.
So which one?
Sir, sorry, sir, you are not audible, so I'm not getting the questions.
Okay, can you hear me now?
Yes, sir.
So in AV malformation, the connection is between which artery and which vein?
Sir, probably
Is
the
it between
interlobar
renal
artery.
artery and renal vein?
No, sir, interlobar or interlobular artery or like the peripheral vasculature of the kidney.
Okay. So arterioles and venules, correct? Because that is the
Yes,
place
sir.
where you are going to do the puncture and artery, right?
Yes, sir.
Now, and what is a pseudoaneurysm?
Sir, a pseudoaneurysm is actually it's not an aneurysm when there is a dilatation of the vascular system. It is the collection of the collection uh, the abnormal collection of the. So I'm not getting the exact definition, sir.
Okay, Samit, you can say.
Sir, it is basically it is a blood collection outside a particular ruptured artery, uh, but that is surrounded by a intervening tissue.
Okay.
So that is uh, basically a pseudoaneurysm, like an outpouching where it is blood collects due to the ruptured vessel, and that is surrounded by tissue.
So what is the difference between AV malformation and Pseudoaneurysm.
So, pseudoaneurysm is due to this, and malformation is abnormal communication between any artery or a vein.
Clinically, can you differentiate?
So, pseudoaneurysm, it is ruptured artery, and there is collection of the blood. So, patient may report gross hematuria, and AV malformation. The patient can report intermittent hematuria.
See, I think
Yes,
we are
sir.
going slightly wrong here. We have to discuss between pseudoaneurysm and AV fistula, not AV malformation. Okay, whenever there is a injury, partial injury to the arterial wall, there will be blood collection in the wall or around the wall, which is walled by the surrounding tissue. And this blood collection is called as pseudoaneurysm. When there is complete transaction of artery and vein, the blood from artery directly enters into the vein, and this is called as AV fistula. AV fistula would have a continuous bleeding, not a very high grade of bleeding. AV pseudoaneurysm would have intermittent severe bleeding. So these are more a radiological image. The treatment for both practically remains same. That is endovascular blockage of these connections.
Angioembolization.
Right. So, Samit, whatever Sir has said, can you just repeat so that it goes into everyone's mind?
So, pseudoaneurysm and AV fistula. So, pseudoaneurysm is basically due to the collection of the blood secondary to the rupture of artery, and which is
No, what he has said, partial.
देखो
Sorry,
pseudoaneurysm is the wall of the pseudoaneurysm is not formed by the wall of the artery. Number one.
This by the surrounding tissue.
It is formed by the clotting factors.
Oh, yes.
Fibrins, fibroblast, platelets, ये सब मिला के वो उसका एक कैप्सूल बन जाता है, pseudo कैप्सूल के जैसा. और it looks, and then it is called as pseudoaneurysm. So collection outside the wall of the artery, covered by the wall is formed by the clotting factors. That is called as pseudoaneurysm. And AV fistula already sir told कि AV fistula ये artery and vein एक दूसरे से communicate हो गया मतलब AV fistula. वो ट्रॉमेटिक रहो, स्पॉन्टेनियस रप्चर हो, जो भी एक दूसरे के साथ कम्युनिकेट होगा कि AV fistula.
Yes. And aneurysm, intermittent bleeding, but a gross hematuria. And AV fistula, it will be almost continuous, right? But not very severe, unless and until the very major vessel is open. And the treatment remains the same for both of them. Okay?
Yes.
Okay. And if there is a mild hematuria, not very gross hematuria, how will you manage it?
So then we should, if the patient is hemodynamically stable, then observe and maintain adequate hydration. And if there is clots which are seen within the nephrostomy tube, minor clots, then we can flush the tube.
Why want to flush the tube?
If there are clots and it is
to disengage the clots and increase the bleeding.
If it is not a very gross hematuria, then conservative management can be done. Correct? So you will hydrate the patient. You want to give good antibiotics because this can be because of infection also. So you want to cover patient with a good antibiotic. Okay. Just check whether calcium and other factors are okay, whether vitamin K is needed or not. That also you must know. Right? And some people also give pause. Correct? And wait and watch. And if the patient is deteriorating, then immediately do angiography and embolization.
So So again to revise, if there is a minor bleeding, hydration, bed rest, control of blood pressure, antibiotics.
Fine.
Okay. And then observe.
Right. Okay. Fine. So is it clear?
Yes.
Fine. So can we go for a second short case? Sir,
सर 11
Aditya
बजे
sir
के
is
बाद
laughing.
ताकत नहीं बाकी रहती सर.
Okay. 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 Fine. I think we have covered quite a lot. In second inning we will do it. No problem.
यूरोलिथियासिस बड़ा टॉपिक है सर, और एक आधा क्लास ले लेते, कोई इशू
Okay. बाद में ले लेंगे.
नहीं.
Start. Okay. Good night.
Good night,
So,
sir.
boys, just revise or read about the radiological investigations, read about PCNL in utmost details. There are two very good articles by Gyanendra Sharma. One, I think Paras has put in the group. There is one more article which has got published in the World Journal of Clinical Cases. These are two articles which everybody must read. It gives you finer details about various steps of PCNL. And then knowing about the complications and how to manage them would again be important. You see, remember that initially TURP was considered a difference between a general surgeon and a urologist. Then PCNL is being considered as a factor which differentiates you from any other surgical specialist. So knowing everything about PCNL is extremely important. If you get a stone case, this is a tricky situation because any mistake here will be very difficult to excuse. You see, you have a very difficult kidney cancer case or a prostate cancer case, minor mistake there can be excused. But stone, BPH, these are cases where there is no scope for any major error. So please read them in utmost details.
I agree with you. Because other cases like CA bladder, CA prostate, even the examiner, if he is not daily dealing with all these things, may not be knowing all the details or the latest, theories and other
सर
genetics.
इसमें प्रैक्टिकल पूरा नॉलेज रहना एकदम कंपलसरी है. कुछ भी
Yes.
पूछ सकते हैं, वायर गया नहीं, वायर निकल गया, वायर किंक हो गया, एम्पला सडनली निकल गई, ब्लीडिंग शुरू हो गई. जो एग्जामिनर ने फेस किया है वो कुछ भी पूछ सकता है.
Correct.
Absolutely.
Right.
Yes.
So I've put the other Gyanendra Sharma article also in the group. Please go through these articles. This gives you details, every details about the small intraoperative problems.
Good. So after when we go for the second round, we are going to do all these things again. So all of you should be ready by then. Okay? Fine. Good night then.
गुड नाइट सर.
Right, sir.
Good night, sir.
Good night.
Good night.
Hello. Hello. Hello.